everybody muted so you don't hear, and we don't hear background sound. So to make a comment, use the chat function that you'll see on the screen. We'll try and look at questions and group them together and do a little bit of sharing around the questions that come in. We have had a couple in advance, so we'll try and pick up those. We're going to be recording the session today, so our words of wisdom can be heard by lots of people. So that's good. What we want to happen today is to try and increase understanding about this really important report on health inequality, north-south, called Due North, and particularly the potential of the voluntary and community sector to impact on health equity for the North, and to look at how we can promote health equity for the North as well. So Julia, if you are ready, I want to introduce you. Is that okay? Hello. Hello, Julia.
Hello.
Hi, I'm just going to introduce you, so to all the members of the conversation. Julia Weldon is the Director of Public Health at Hull Council in Yorkshire Humber, and was a panel member of the Due North inquiry. And a really warm welcome, Julia. Looking forward to your overview of the findings of Due North, and I think there are some slides to go with your overview as well.
There are. Thank you very much. Do I just ask you to move the slides on when I'm ready?
Yes.
Okay. Good afternoon, everybody. It's really great to be participating in this webinar with you. It's my first experience of one of these. I'm sure lots of you are also having a first, so good to do that together. My role over the next few minutes is really to give you an overview of Due North, just give you some insight into the development and the recommendations, but really to take account of that in the context of the conversation we want to have today, which is around the role of the voluntary community sector and social enterprise in both being involved in the delivery and the contribution to feedback about the work. Due North was commissioned by Paul Johnston in 2014 as an independent inquiry. Paul is the regional for the North, the whole of the North, Director of Public Health, and he directly reports to Duncan Selby at Public Health England. The inquiry wasn't about duplicating other inquiries about health inequalities. What we were looking for was some fresh insight into policy and actions to tackle health inequalities within the North and between the North. And it wasn't about us saying it wasn't really about this reiterating North-South divide, because we know that there are inequalities in the rest of England, but recognising that in the North, the inequalities are more stark. Although 30% of the population live in the north of England, there are 50% of the health inequalities are in the north of England. So whatever we learn about how we address health inequalities here, we can use that learning to transfer elsewhere. So if you can move on to the next slide for me. Thank you. The causes of health inequalities are the same across England. They're no different. The differences in poverty, power and resources needed for health, exposure to health-damaging environments and opportunities to enjoy positive health factors, the same for everywhere. But as I said earlier, the North is disproportionately affected by those health inequalities. And we know that the austerity measures imposed by the government are impacting more heavily on the North. We've seen that in terms of some of the increases in things like food banks, and the increases in child poverty that we're starting to see. Devolution is beginning to be a real possibility. You'll have heard about the Manchester announcement earlier in the month. And in the context of Due North, devolution was very much part of our discussions about how we could use the powerful mechanisms of things like combined authorities and city leadership, etc., to ensure that there was more local decision making about how budgets were used. And finally, the other bit of the context for us in terms of understanding the cause of health inequalities and the recommendations was recognising that local government were playing a different role since the implementation of the Health and Social Care Act in 2013. And so we wanted to bring a northern perspective to that debate in that context. We can move the slide on. Can I do that? Is that okay? Thank you. Just to give you a sense of what we mean when we talk about health inequality. I'm sure I'm talking to an audience who understands, but I think sometimes it's good just to remind ourselves that when we're talking about inequalities, we're talking about the systematic difference in health between social groups that are avoidable by organised action. So they're avoidable, and therefore when they arise, they're unfair and unjust. It's unacceptable that in a place like Hull, where I am based, that life expectancy for men in our most deprived ward is 10 years lower than life expectancy in our least deprived ward. And similarly, it's a similar figure of about 8 or 9 years for women. And if you look, we just tried to demonstrate this through this slide, where if you follow a bus route through Hull, it's not quite as neat as a tube stop map, but you can see the differences between life expectancy. And life expectancy in itself isn't always the best thing to look at, but if you look at quality of life expectancy, so the age at which people start to feel that they can't continue to do the things they want to do, that they're not able to spend time with their family in the way they wanted to, not able to work, the differences in quality of life expectancy are just as stark for us in Hull. Poverty drive social inequalities, and social inequalities are drive health inequalities. And what we're trying to address in terms of Due North was how do we, across the North, look at recommendations for what the North can do for itself and what we might have to ask for a broader response from government. If we go on to the next slide. This slide, I hope you can read this okay. Both of these diagrams have come from my annual report this year. You'd expect that my annual report focused on Due North because it was such a privilege to be involved. So I used it as an opportunity to talk about health inequalities in my annual report. If you don't know Hull, there's a little map of Hull there on the slide. On the right-hand side, you can see two adjacent wards. One is Orchard Park and Greenwood, and the other is Kings Park. If you look at the living in child poverty, you can see the difference between those two adjacent wards. That in Orchard Park and Greenwood, one of our most deprived wards, we have about 50% of children who are living in poverty. And in Kings Park, there's 1 in 11 living in poverty. If you go down and look at poor health, at the bottom, 1 in 7 in Orchard Park report poor health, 1 in 30 across Kings Park. Of course, as I said to you, poverty drives social inequalities drive health inequalities. We know that if we can provide the best start in life for children, those benefits accumulate across life, and it means that children are more likely to do well at school, be ready for school, they're more likely to achieve at school and gain qualifications, they're more likely to get employment, and they're more likely to make the life choices that means that they have better health throughout life. inequalities like this exist throughout the city of Hull and throughout the north. So for those of you who work in the north and operate in the north, this isn't a surprise to you, but very much a way of demonstrating to our political decision makers the differences in life chances that inequalities create. Okay, do you want to just move on to the next slide for me, please? So, in terms of the actions to tackle root causes, the Due North panel proposed 3 actions. The actions were developed having had an opportunity to have 3 sessions where we invited experts in the field to come and provide evidence to us, and also 3 sessions that focused on making sense of that evidence that was brought to our attention to develop the recommendations. And the panel proposed these 3 actions that you can see here. That the actions needed to tackle root causes of inequalities were about tackling poverty and economic inequality, promoting healthy development in early childhood, and sharing power over resources and increasing the influence of public over decisions. And I'll explain a little bit more about each of those. They are underpinned by all of the evidence we heard, but of course there'll be no surprises to those of you that are very familiar with Michael Marmot's work. Again, what we were trying to do with this, though, wasn't recreate that report, but create a report that was couched in what can the North do for itself and what does it need to call for support from others. Sorry, can you just move the slide for me? Thank you. So of those 3 actions, we looked at the recommendations, and as I said, we looked at 2 types of recommendations, which I've just described to you. And just a reminder that if you read the foreword, if you've read the foreword, you'll see that Paul Johnson said it's not a grim up north. It's a fantastic place to be born, live, grow, work, be educated, but not everybody has the chances to do that, and it's unfair and unjust that that's the case. But there are lessons for the whole country, not just for the north, from this report. Okay, so you just move on. Due North is not a political report, but we were very conscious as a panel that you can't ignore the politics and the decisions that create the circumstances in which people are living. And there's no doubt that during the previous government years, when they focused on child poverty and set a target for child poverty, that you saw there was an emerging positive trend towards improvement. Since the austerity measures, the cuts and welfare reforms have been implemented, the reforms have fallen more heavily on the north and the south, and certainly when you look at the burden of cuts within local authorities, you can see that there's been a significant burden on some of the most disadvantaged areas for local councils. So it is apparent that austerity measures have disproportionately affected the poorest. And although we've had a real focus in a lot of areas on economic regeneration and getting people into jobs, and we're very aware of that, and that's really encouraging, what's been really evident for us, and was evident through the evidence presented to us, was that the focus on economic growth wasn't always aligned with or embedded in addressing social determinants. And where it wasn't, you were very unlikely to see a difference in health outcomes, although you might see regeneration of the place. It certainly wasn't having the positive impact on people that we were expecting. So can you just move on for me, please? The recommendation then around tackling poverty and economic inequality focused on a number of things, all of which I don't have time to go into. So I've tried to summarise some of the key things that I thought might be of interest to you and that we can talk through. Developing better locally designed supports for people moving into work. We know about our local populations and we know about what's on offer in the communities, and having the ability to make the decisions about high quality employment locally, good working conditions and routes into work, and aligning those was seen as really, really important. As I've said in Hull, we've had some fantastic economic regeneration and an increase in jobs, the announcement of Siemens coming to Hull. But what we've got to be really clear of is that jobs are no longer a way out of poverty for many people. For many people, being in a job means working 0 hours or on a minimum wage. And so the majority of those, I mentioned about 1 in 2 in some of our most disadvantaged wards, 1 in 2 children living in poverty. They're children who are living generally in the majority with parents who are working or a parent who's working. And that work no longer guarantees a way out of poverty. So one of the most important recommendations for us was around promoting the living wage. And I know that there's a question about disability in the webinar today, and we talk about promoting the living wage, but also a minimum income for healthy living to ensure that those who aren't able to work are not left living in poverty as a result of a disability that means they can't work. Living wage is an issue, a contentious issue, I guess, for places where there are significant cuts being made, but nevertheless, the panel felt it was really important to make this a recommendation. It's a recommendation in my DPH annual report as well. For those of you that haven't read it, it's worth reading Work That Pays, a report from the Living Wage Commission that was produced last year. We recommended using joint spending power to promote good employment. So there was much discussion about how we work together through our local economic partnerships, where combined authorities haven't already started to look at how they can work together to promote good employment, that local authorities start to talk to each other about that. Housing, obviously, really, really important issue for health inequalities. Improving the quality and affordability of housing is a way of tackling fuel poverty, particularly. And living in cold housing costs the economy, costs the NHS alone £2.5 billion in childhood admissions. And then, of course, if you are living in poverty, it's much more difficult to get credit, and therefore we have more people who are servicing very, very expensive debt, and the causes of obviously the cause of mental illness and physical illness. So hence the recommendation around credit unions. Okay, to move on. Thank you. So moving on to the second recommendation. This is the recommendation that supports best start in life, and it's not worth. This is a slide that focuses on the large proportion of children growing up in poverty, which we've already spoken about. The 16,000 children in Hull growing up in poverty, and as I've already said, the implications of that throughout life are huge, and it's really, really important that we tackle that. Children who start behind stay behind, and children in poverty are more likely to die in the first year, be bottle fed, become overweight, perform poorly in school, die in an accident. They're more likely to be a young parent, more likely to be out of work, living in poor housing, working in poverty, and report poor health. So you can see if we don't intervene, those inequalities remain throughout life. Health of children is generally worse in the north, and that's a direct link to the inequalities that we're talking about here. And none of it is inevitable. I think that's a really, really important point that Due North is making. Can move on for me, please. So just to summarise the key recommendations, this one area, I think more than anyone, picks up the recommendations from Michael Marmot's Health Inequalities Plan. The monitoring the recommendation about increasing proportion of overall expenditure, allocated to giving every child a good start in life, picks up on what I was saying about if you invest there, the benefits accumulate throughout life. I think just go back for me. We've just moved on to the slide. I'll carry on. Ensuring access to good quality universal early years education and childcare helps to break the link between parental poverty and child life chances. But
Julia, just a quick note. We've got about 3 minutes.
Okay.
Okay. Thanks.
Oh, no, sorry. And then, well, if we just move on then to the recommendations, or under recommendations 3. This one is around democratic legitimacy. We know that if people have power over decisions, it improves health and well-being, and it's an indicator of how people feel involved will be how many people turn out to vote, for example. And we know that in more disadvantaged areas, less people come forward to vote. So the recommendations here are around participatory budget approaches, about ensuring that we allow communities to hold us to account for the decisions that we make, through making sure there's visibility about the decisions and the results of those decisions and actions. And an example around how we can share resources and power, things like setting up publicly owned mutual organisations for providing services. So if you just move on to the next slide, nearly finished, honestly. It's hard to put a 70-odd page document into 15 minutes. There are some actions here for central government that are worth us all looking at. So some of those actions that I've already spoken about will require both a local and a national action, but some examples here of the things that we think that central government need to do. And then finally, the last slide covers the NHS and the actions that the NHS could take. Although this report wasn't about the NHS, what we felt was the NHS needed to build on its considerable achievements in mitigating some of the effects of social and economic inequalities by looking at really supporting us around integration of services that prevent poor health and poverty across the life course, and ensuring that they took really seriously their role in championing action on health inequalities and in championing local employment and building the capacity of the community and the voluntary community sector around us. Phew! So that's the sort of essence of the presentation. Where next, I think, is we're still waiting for a final Public Health England response. There are now emerging models of devolution. You've seen the Manchester announcement around health and social care. We've already had our Health Equity North 1 year on review, which a year ago Due North was commissioned, and we've talked about where we are now. And we now need to, from Due North, develop our action plan for Health Equity North. Thank you, everybody.
Julie, that was great, and appreciate very much trying to sum up a long and really important and complex report in short time, so big thank you. We're looking now for comments or questions from participants, and I don't see any at the moment. So just one thing to ask participants, perhaps. I wonder how many of your organisations are living wage organisations. Just wonder how far we've got on that. Do people want to just comment on that?
They can only type the questions on.
Yeah, they can put that. You can type in yes we are, no we can't, or whatever.
While we're waiting for that, the debate is interesting when you look at our small and medium enterprises, because there's a recognition that it's more difficult for small and medium enterprises to promote the living wage, but nevertheless that people are committed, and it's good to see that some of the community and voluntary sector organisations are living wage employers despite some of those challenges, and I think we should be sharing that success so people feel they can. And be asking the question about, asking the how can we question rather than deciding that it's too difficult, I think is the thing to be doing. That's
a very good point. Yeah, I see Newcastle CVS is a living wage employer. Anybody else? What's public health like? Public Health England, say. Anybody know? No. Okay, Julia, let's just asking you some questions, perhaps. I think one of the themes of today is about how the voluntary and community and social enterprise sector can contribute to turning the ideas of Due North into practice. Do you want to tell us a little bit about that, how you see that happening, and perhaps what's going on in Hull as well?
Yeah, I think one of the things that we didn't get time to touch on was how important, if you read the whole report, the role of the voluntary and community sector and the issues around community resilience, well-being in the community, people having more control over their lives is really, really high. And of course, there's a lot of that centrally to the 5-year forward view, the NHS plan. What we were concerned about was that there might be a bit of rhetoric around that, and where suddenly we decided that voluntary and community sector need to be equal, and that we want them to be equal and reciprocal partners in decision making, and there hasn't been necessarily the respect for that in the past. And you can imagine that some of our voluntary and community sector partners have said, well, yeah, okay, well, we would have done that if we'd have been part of that partnership, truly part of that partnership for a long time. I think now is the best opportunity we've ever had, because people are starting to talk about thriving communities and realising that that working alongside people in that equal and reciprocal way to co-commission for well-being is the only way forward, particularly at times of austerity. So in Hull, we've been working with our voluntary community sector. We've just successfully got some support from Building Health Partnerships to develop our approach around thriving communities. And we've identified 3 priorities, one of which is to work with them to do some co-commissioning around social prescribing, particularly focusing on mental well-being. I think that there are practical things about engagement and getting involved and building that partnership and relationship, making sure that VCS have a voice on the health and wellbeing board, and that they're able to participate. And also, I think it's the role of, for me, it's to challenge back, which I think you do very well, the knowledge of your communities and the needs of those communities. Oh, my goodness. That sounds like I can't
Fire
believe
alarm.
that sounds like a fire alarm, and it's not.
Attention please, attention please. We have an emergency within the building. Please leave by the nearest available exit.
I do apologise. I think that's for real. So I'm going to have to go.
Julia, I think we probably ought to move on, perhaps.
Attention please. We have an emergency within the building. Please leave by the nearest available exit.
Are you actually leaving the building? You sound you off. Colleagues, I think Julia has had to evacuate the building. One of those perils of doing this sort of thing. So I think we will turn now to Warren Escadale, who is the acting Chief Executive of Voluntary Sector Northwest, one of the other regional voluntary sector networks. And Warren's been involved in the writing of this report and some of the background research as well. And Voluntary Sector Northwest have played a very active role in Due North. So Warren, I think you're going to talk about the voluntary sector response to Due North. Is it just theory? Is there some practice? So over to you.
Thank you, Judy. Can you hear me?
Yes.
Hi, can you hear me?
Yes.
Sorry.
Yes, can hear you. Yeah.
Good. Good. Right. So I was asked to pull together a presentation about the role of the voluntary community sector in taking forward the recommendations of the Due North report. So we were involved in not only sitting on the inquiry but in drafting papers. So I co-wrote the one on the economy and the way that the economy links into social determinants of health. So it was the economic determinants of health paper that I contributed to the inquiry, which fed into the final Due North document. So on the day of the Due North stocktake event, which is the bit Julia was mentioning, which was the 1 year on. So the report came out sometime in September, so it's not been a year since the report, it's just been a year since the steering group formed and then commissioned that report. So on the day of the 1 year stocktake event, I mean, it was a key feature that there was presentations from other voluntary community sector organisations talking about the role of communities in getting Due North or something like Due North to work. So on the day there was Roy's Community Association from Bradford, and they began to talk through their approach to community participation approaches to health and well-being, and their engagement of patients, their support for patients to be strategically engaged with conversations, and the development of peer support in their area. And one of the other things that came out on the day was it was a couple of days after the Public Health England NHS England report on community participation approaches to health and well-being. So there was a definite drive to think about how communities should be engaged in tackling health inequalities, and that was kind of one of the things I wanted to talk about. And my focus when I spoke was about how do we make the most of what the sector has to offer in tackling health inequality. So just to run through a little bit about who we are. We're a Regional Voices partner. We're one of those other areas that supports regional voices nationally. Which is a Department of Health VCS strategic partner. Our focus as VSNW is three policy areas: health, economy, and thinking about how we create change through the sector. So you can see how Due North was an important part of what we're about and what we want to be about and how we see things working properly. We're a membership organisation, and we've got a health and social care network with over 500 contacts. So we wanted to pick up on the report and think about how the sector should be involved and how we should think about supporting the sector to be involved. So it wasn't necessarily going through, here's all the contributions of the sector and this is the ways they're good. I think that was the job of other organisations like Roy's Community Association and Liverpool Housing Trust to talk about on the day. So I wanted to make it clear about kind of the makeup of the sector, which for me informs the strategy for working with the sector. So we think that, well, our evidence is that there's over 71,000 groups in the north. They've got an income of just short of 5 billion. They employ 175,000 people, and there's about 4 million people volunteer once a month and 6 million volunteer once a year. So it's a substantial amount of activity And what we found that was most of it wasn't necessarily through procurable groups, that we found that the majority of the sector are small, local, under 10k groups that really aren't commissionable in a traditional sense through procurement techniques. So if you wanted to make to get the sector involved, our opinion was that you needed to think not only about how you work with VCS providers and social enterprise providers, but also about how you kind of get that massive body of local community groups engaged in the right way. And as you can see from this bar chart, we used NCVI Almanac data, and it's something like 79% of the sector has an income under 10k. So you can get that real sense of that it's the iceberg of the sector that's very much under the surface that isn't procurable. And that was a kind of the way we wanted to get public health directors of public health and other leading public health officials to think about how they work with the sector. So we developed a short briefing paper. It was a bit crude and crass, but linked to Due North, and we were looking at how to involve the sector, and so this was kind of something that informed our thinking. And we went out and consulted groups in the Northwest, and eventually that work was turned into a short briefing paper by Regional Voices, and hopefully informs today's webinar. The bits that we thought were important, I hope you can read that. So it's all a bit blurred there, isn't it? It's merged on my screen. I don't know if it has on anybody else's. But essentially, it was thinking about how you engage community. So how do you understand what's working and not working? So our messages were work with trusted people. So work that we've done in the Northwest has been with community asset investigators. So we've asked people to go out, and it was a specific piece of work in this instance where they would go out and talk to people in their community, so people from the community talking to people in their community, and we were looking at how do we engage communities it was in the early years agenda. So it was community asset investigators going out and talking to parents of young people and asking them what was useful, what helped them as a parent, and what were the kind of things that they needed. And it wasn't all about the voluntary community sector. There were key elements around community hubs, Sure Start centres, children's centres, there were childcare, but there were other features such as green spaces, play spaces, and even supermarkets played a key part. And one of the key things was about access and about how people connected to other people who could help them and how they could connect to resources. So it was a key piece of work in understanding not the kind of the public sector approach to how we get communities involved in tackling health inequality, but how we understand how health inequality and health equality works in a real space for people. So there were other pieces of or other examples we were giving about how we understand what's working and not working that's kind of outside of the ambit of the kind of the more formal approach to quantitative data around JSNAs. So in East Cheshire CVS there's a great piece of work being done with the sector where they've gone out and talked to local groups about the kind of evidence that they've got about what's working and what's not working, and that's again been collected together and is informing conversations about the kind of interventions and approaches that's needed in East Cheshire to tackle health challenges. There's other pieces of work coming through from LSE and the Health Foundation where they've developed this. It's a grand title, they call it STAR informally, but it's a socio-technical allocation of resource. But essentially it's about how you engage stakeholders in understanding what's going on in their areas and what's working and what's not working. So it's outside that kind of formal process for thinking about resource allocation, but that gives you a real insight as to what really is working and what really isn't working. And that's one of the key features of what Involve Yorkshire and Humber side have been doing with Professor Mark Campsey around rapid reviews. We also wanted to highlight how larger voluntary sector organisations have opened up their database to collaboration. So Age UK Lancashire are working with small local groups, giving them access to their data so that they can work together and understand how to help older people in Lancashire in this instance. There was an example on the day of the the Stocktake event around Liverpool Housing Trust using an ethnographic study approach in a report they called Real Life Reform to understand the impact of the cuts on individuals and how that was changing their lives, not necessarily for the better in this instance. So what we wanted to see was better examples of how public sector agencies and community groups and voluntary sector groups are working with communities in order to understand what's working and what's not working. We see that as a key way forward in creating change. One of the other ways we wanted to talk to partners about was thinking about the world of work. So we wanted to think about how organisations or how public sector organisations engage with the new work programme. So one of the key features of devolution is that a lot of the combined authorities are asking as a minimum requirement that they joint commission the work programme. So we wanted to see how we could change, or how we can get people to think about changing how that works, so how it might link to health inequality, how it might link into health and wellbeing boards and their approaches to thinking about how the work programme should link to them. So it was, in a sense, it was reclaiming holistic delivery as part of the work programme, which for us would bring benefits to, it would we feel it would incline greater engagement of voluntary community sector groups in that kind of delivery that helps people and their beneficiaries more. So it wasn't necessarily directly trying to get groups involved, but to create the system by which the sector can be engaged and change created that tackles health inequality. We also wanted to highlight how we needed conversations with local enterprise partnerships. So we want to find out how health and social care groups are involved in the latest round of lottery, EU lottery conversations about delivery from 2016. So although the LEPs set out the broad parameters of the kind of jobs they want to create, what we wanted to do was to encourage health and social care groups to get involved in the best way for them and think about how they create the jobs that help people who are cut off from employment due to health challenges or health inequality challenges. So we think that if you're going to genuinely tackle social inclusion, then you need those kind of groups involved in that agenda rather than the kind of more mainstream economic development groups that you might naturally attract through an EU programme. We wanted LEPs to think about how they think about well-being. So for us, this is a priority for how LEPs think. It's not an economic agenda. It shouldn't be just about creating jobs. I think we've seen the minimum job creation activity going on over the last 5 years, where we have more jobs, but they're less well paid, and they're not so good, and they don't really help people get out of poverty. They're not a route out of poverty, they're the route into nominal employment rather than something better. They're not about careers or families or lives being improved, or social mobility in any traditional sense. So we wanted LEPs to begin to think about how well-being should be more of a priority than job creation. It should be about how jobs are a route to something beyond that minimum first step onto employment. It needs to be a genuine step towards greater employment for individuals and families. So we wanted our proposal would be a well-being premium included as part of the funding. So in the East Midlands there's been a conversation around where 80% of the funding is for job creation, but then there's a discretionary 20% on the top of that, which would be about well-being. So thinking a bit more creatively about the kind of job support and tackling worklessness initiatives that we want to encourage. We also wanted LEPs to think more creatively about their community grants programme and what that looks like, and could it be matched through, for example, CCG grant budgets. Bottom line there really is how can we make measuring well-being, not just jobs, the success criteria, and I think that would go some way towards creating the right circumstances for the sector to get involved in a health inequality agenda, a genuine one. I think a key part of the sector's role is as providers. I know I've emphasised that below that the waterline, 80% of the sector, but there are providers out there, and we need to encourage them to build in co-design and co-production and make sure that's a fundamental part of their activity and continues to be so. We need to support the sector's role in prevention work and link it back to holistic delivery and well-being, and we need to emphasise the sector's role in connecting silos and funding streams. So we're seeing devolution as place-based budgeting, but this is something the sector's been doing for a long time, pulling together different funding streams and working on it being for the local community as a priority rather than simply straightforward delivery of whatever funding stream they're in receipt of. I don't think we're necessarily I think we have our own challenges, and I do think there's a need for us to change as well. So we need to champion the living wage. I know we've got involved in a race to the bottom often as providers, and we need to think about how we stop being involved in that way and genuinely champion the living wage. We need to make sure that volunteering isn't job substitution. We need to think about how we support a race to the top. I think we've been involved in a race to the bottom. So I think there's something in here about how we make offers to commissioners around our legacy work or our social value work, and how we connect the benefits of our delivery to communities. So we might be involved in a contract for 2 or 3 years, but how can we get the community to make the need for us to deliver that contract in 2 or 3 years' time less necessary? And I think that needs to be a key part about how we work as providers and link back to communities and community groups. I think we need to transform our VCS infrastructure levers, and I don't just mean local infrastructure, I mean equalities infrastructure organisations as well. And it's something that's kind of gone under the radar. We had the recent NAVCA report on the future of infrastructure, which very much said it's not working as it is, and we need change. It didn't go into too much detail about what that is. But I think if we think about how we need infrastructure to work in a context, so for me some of that's geographic, some of that is around health inequality, and then work backwards from that, we can provide a context by which we need infrastructure to be thinking and working. And some of that is through initiatives like social prescribing. So how do local infrastructure organisations connect to communities? How do they support communities to engage with GPs? How do they support them to engage with patients and create the mechanisms by which we can realign and coordinate without crushing local community spirit and activity in a way that supports the bigger goals that we're all after. I think something that we've not had for a long time is an effective workforce strategy. I don't know if any of you remember Skills Third Sector, but they very much disappeared. I think they're formally a platform within Skills for Health, and it's quite difficult to see where this skills agenda fits in. We don't even get bombarded with emails about apprenticeships and modules around volunteering and fundraising as much as we used to. It's not really a very effective workforce strategy for the sector. So I think we need to regain a full-blown workforce strategy for our sector that runs alongside a public sector workforce strategy, but uses light touch initiatives like co-location. So 42nd Street co-located one of their workers with, it was the PCT in the old days, but it was the CAMS team in Thameside and Glossop, and they found that they changed the culture by which both organisations operated. It changed the conversations they were having with each other, and it ended up where patients were more engaged in conversations about their own delivery and support from the public sector and 42nd Street to such an extent that the interventions required dropped to level for most people involved in that. I think one of the things that came through from one of the key messages I haven't put here is it's something about the sector reasserting its economic role. So I know we saw Julia mention credit unions earlier, but I think it's that kind of community economic development role, how we're involved in creating prosperity and long-term change in the communities for which we're working. And it's thinking about that rather than almost sinking into this is our job, this is our bit, this is where we need to have our conversation. It's trying to get back to a point where we work more collaboratively and more collectively, certainly at a local level. I think one of the other key areas which Julia mentioned was as lobbyers and campaigners. So we need to use the Social Value Act to lobby for the maximum social value from spend, and that includes our own, and we need to think about how social value is used in order to tackle health inequality. We need to advocate, well, we do advocate on behalf of communities and make sure that no one gets left behind in an economic context. So there's been some interesting work in Manchester, not Greater Manchester, but Manchester, where there's been a conversation with one of the economic development vehicles within the combined authority structure, talking about how do we we've had a lot of wealth created in Manchester over the last 15, 20 years, but we've still got the same amount of poverty. So there's a sense in which we haven't connected the wealth creation in Greater Manchester to the poorer communities, so they've almost been left behind whilst we talk about a great big Manchester economic renaissance. So I think there's a role in thinking about how the sector reconnects those communities to the growth that is going on, or helps create communities to connect to opportunities and economic opportunities at that. If we can connect to them, then those social determinants become much less determining on people's lives. I think we need to make, so health inequality needs to be part of the devolution conversation. So we've seen that Greater Manchester's got this £6 billion devolution deal. It's the same money that's been in the area, but it's just new conversations possibly about how that money is invested and where it goes into. And for me, there's something about what are the priorities, and it can't just be that we've created a way to co-opt health and social care spending in order to create minimum jobs, but we need to think about how some of the economic spend should be co-opted to create well-being. For me, is the key battle within, if you can call it that, within the new negotiations that are going to go on over the next year, which will create a new kind of policy agenda outside the Westminster bubble that will influence the future of many local areas. And I think it's a key area for us to be interested in and make sure that comes out with the right way for the sector to get involved that supports communities. And some of this is about how do we marry the best in public sector interventions with the best that the local community sector can offer. And so there's elements of unleashing community potential or helping communities to help themselves, which for me is that far more sustainable public service reform agenda which Julia was talking about. And it's how do we marry the best professional interventions alongside that kind of more bottom-up community participation approach. And I think we need to be able to articulate why that needs to be half the story rather than a tenth of the story, which it seems to me a tenth is perhaps an overestimation of where we're currently at. So just the last slide now, and I think this is partly propaganda, but this is the kind of things that we're thinking about how we support the sector to engage in tackling health inequality. So social prescribing, as I've mentioned, which I think changes those local relationships and really drives positive sector development in the right way, not only for community groups but for infrastructure organisations and the connections with those larger voluntary and community sector organisations that have been contracted in areas. If you can tie that circle together and think about how they support each other in the right way, then I think you've got the beginning of something that can really help create change. I think we need to explore the future of volunteering. We need to champion social value, and public sector is very much up for this. We need to link large providers into communities, as I've mentioned, get involved in those devolution debates with an emphasis on what good devolution is and how we get strategic engagement with those combined authorities and those agencies and bodies that are really driving devolution discussions and public service reform agenda. We need to think about how we work with Northwest with Health Watch organisations more broadly on the devolution agenda. They should be at the forefront of engaging patients in the kind of change that patients need, and I would think that should be a minimum requirement of what Health Watch should be up to at this point in time. We need to champion communities, and some of that work we're doing through our Thriving Places campaign and through championing the economic role of the sector. That's things we're doing, and I think what we've done with Regional Voices is develop a briefing that outlines some of these things and a few more things, and begins that conversation about the kind of strategic approach to sector engagement and sector engagement in a tackling health inequality agenda. Thank you.
Thanks, Warren. That's great, and there's an awful lot in there, lots of interesting things to follow up, I think. I just wondered, Julia, now you haven't had to rush out to put a fire out or whatever, what's your first response to that? Is there something in there that Hull would want to take up, say?
I think, apologies everybody, we couldn't have scripted that, could we?
No, you couldn't.
I think, unfortunately, I didn't hear the whole of the presentation, but you know, I heard Warren's ideas coming through, and I think what was really good for me to see and hear was the strong leadership role, almost system leadership role that the voluntary community network can take in providing a focus for how we implement Due North, and that there are examples around. I talked about thriving communities, Warren's talking about thriving places. The language is very similar. I think our job now really is, across the north, to just make sure that we have that level of engagement across the public health community, the voluntary community sector community, and other agencies, to look at sharing some good examples of how we're implementing Due North and testing out some of our ideas.
I noticed, Neil, Julia and Warren, that there's a little debate about LEPs, local enterprise partnerships. I just wonder how, say, in Greater Manchester, where there's a big LEP, and in Hull, where there's a LEP that's focusing on big, heavy engineering projects, where's the link to health equality in those?
Do you want me to answer first? I think
yeah.
You'll see my response to Neil. I certainly don't think that we're maximising the relationship with our local economic partnerships. In Hull, we also have something called a city leadership board. We have one city plan that brings all of the partners together across Hull, including the business sector and voluntary sector. And that's a 10-year plan, and that's really been focusing on jobs, creating economic regeneration. Hull City of Culture is one of the outcomes of that. And LEP are obviously a key partner, and they have a role across the Humber, and they are focused on economic regeneration. I think that for me particularly, the voice of the Director of Public Health isn't being heard through those local economic partnership conversations. I don't think that's intentional. I think it's that there isn't always the understanding of the connection between economic regeneration and the health benefits that has, and the potential health impacts of those decisions. And I was talking to the senior team here in the council, chief exec and my other directors here this morning, about introducing an action that hopefully elected will accept, that the local elect will accept, that we undertake health impact assessments for the decisions that they're going to make around economic regeneration. And that might help to get people into that conversation of how can we maximise benefits of decision making and mitigate against some of the potential negative impacts of decision making. But I think there's a lot of work to do. And combined authorities, city leadership, board, this kind of devolution agenda that's happening is great, but it can sometimes confuse it, so we're missing out on some of those powerful levers like LEP.
And Warren, couldn't you say in Greater Manchester it's really a gross GDP agenda, and things like health inequality are on the bottom of it, if there at all?
I think, just going back to the LEP question, you have to remember LEPs have very little resource. They're extremely limited in what they can do and what they can focus on. I know that sounds paradoxical, but it means that they're far more open to proposals and offers that they haven't got to manage or deliver that link into their thinking than you might presuppose. In Greater Manchester, the dominant formula is this conversation between Greater Manchester and central government. So the conversation is, how much economic growth can we create, and how much can we cut the welfare bill. So the economic formula is growth minus welfare cost, and that's been the dominant part. So the reason we've got to the devolution bit was because when we began in 2008, the cost of Greater Manchester on the central government bill was 22.4 billion, and after 5 years of cuts and cuts and cuts and cuts and cuts, a lot of cuts, the bill now is 22 billion. So, you know, it's gone down by 400 million. I haven't worked out what percentage that is, but austerity has had very little impact on cutting the costs of Greater Manchester's welfare bill. Essentially, it's increased it, in effect. It's just been offset by public sector cuts. So we've got to a point where austerity just doesn't work in Greater Manchester, and we need a new conversation. So you can look at devolution positively as an answer, or cynically as the pushing away of the problem from central government. So we've got to a point where the dominant formula isn't looking at jobs. The dominant formula is looking at jobs minus welfare costs. So where you can have a conversation about connecting wealth to communities that are far from wealth and growth, and where you can support communities to address the challenges around the public service reform agenda. So if you have a look at all the combined authorities there's 5 formal ones, and all the other devolution conversations, everybody's conversation is how do we create jobs, how do we reform public services, and it's that combination of those 2 areas where we can get involved and really influence what's happening. And if we don't get that community participation bit right, both in an economic agenda and in a public service reform one, we won't get medium to long-term genuine change that affects that £22 billion cost in Greater Manchester. And that's where we need to be playing in and emphasising what we can do.
So it's that connection, isn't it? Connection of communities to agendas, the growth agenda to the welfare agenda, all engaging people. Those are the really critical things that we need to move on.
Absolutely. The big problem is in Greater Manchester, the model of public service reform is very much complex dependency, which is the follow-on from troubled families, which means targeting those that cost the most, rather than working with communities, which would be my preferred approach, in order to find community-led answers to those problems. But there's only so much community can do if it can't connect to that economic growth, and that's where due north, tackling health inequality, and a public service reform agenda all comes together for me.
Yeah, that's a very neat summing up, Warren. Thank you for that. I don't see any other comments, so I think probably, unless anybody else has got something vital they want to say, if so, put it in words now whilst I start to sum up. I want to thank Judy and Warren. I think those 2 presentations have huge amounts of information and food for thought, so really useful, and I know people will go back to them. Just in terms of the future of Due North, I know we're still waiting for the Public Health England formal response, so I think that will be interesting. The steering group is still meeting, and I think it will look at the follow-on in terms of collaboration, working together, and how that might happen practically. I think there are some short-term gains, small p political, and there'll be some long-term political fallout from the election, so we will need to keep an eye on that as well. I know that Involve and Voluntary Sector North West continue to be involved in the steering group for Well North, so I don't mean Well North, I mean Due North. So if you want to be in touch about that, contact Involve or Voluntary Sector North West, and you'll pick up some of the agenda as it develops. But at that point, I'm going to close the webinar. I hope you've enjoyed it, and thank you for participating. Bye-bye.
Thank you.
Bye.
And if you're still there, there's a link to the evaluation form, which I'll send to your inbox later as well. But thank you very much for being part of today. If you missed any of it due to fire alarms or whatever, I'll make sure the podcast gets shared as soon as physically able. Great to talk with you today.